Okay, on to the next panel. On the 27th of July this year, the Economic Times came out with an article, The 5 Paradoxes of Indian Healthcare. 1. Healthcare is a fundamental right, but it is not fundamentally right in India. 2. Sector attracts investments, but delivery remains contentious. 3. Among the cheapest in the world, yet unaffordable for most locally. 4. Less than 1 doctor for 1,000 patients, but medical tourism booms. And 5. Stark divergence in healthcare outcomes within the country. As a student of biotechnology, the topic of healthcare is something that's very close to my heart. And I'm personally curious to listen to different perspectives on how India can become a global healthcare role model. For this, I would like to invite onto the dais Dr. IITMAA, Country Director, Gates Foundation, Dr. Preeta Reddy, Vice Chairperson, Apollo Hospitals, and Mr. Sasi Shankara, Partner, McKinsey & Company. To moderate the session, we have Mr. Prashant Vasu, Class of 1994.
Good afternoon, everybody. And thank you very much to the IITM team for kind of energizing us soon after lunch. I'm sure it must have been a sumptuous lunch here at Leela. To get us started, in the spirit of now mentally energizing us, first of all, I'm as nervous as I'm delighted to be with this panel. Almost all of you are friends, and the easiest thing to do in such a panel is to get the panel to speak very soon, and all of you to speak very soon. But in the spirit of getting us started, a quick question. We started the panel was kicked off on a rather sobering note about Indian healthcare, but I'm going to flip the equation a little bit with a little quiz to get us mentally energized as well. 20 years back, white pandas, black rhinos, and tigers were all considered endangered species in 1996, around that time. The first question I have for the audience, and the panel is also open to respond, is how many of these species are more endangered today, 20 years down the line? All 3 of them, 2 of them, 1 of them, none of them? Do you want to? One of them? Okay, how many for 1 of them? Very good. How many for at least 2 of them? 2 of them. Terrific. How many for all 3 of them? All 3. Terrific. So that's the majority. And how many for none of them? Okay. Actually, this is a fantastic audience, I have to say. It's an intellectually charged audience. Or you must have read the book called Factfulness. That's probably it. You must have read the book as well. The answer is none of them. And I don't know how many of you, so a round of applause to this audience. It's generally, apparently, less than 7 out of 100 people get this right, which means that our guess as human beings is worse than what chimpanzees would guess. But this is a terrific audience. So good. So on that note, since the broad message of this book called Heartfulness is that the world is getting better, and I'd like to start this panel on a celebratory note, requesting each of the panelists to share what do you think are the 1 or 2 things we should be celebrating about Indian healthcare. Nachiket, you want to start us off?
So there are a number of things that we have done well. Over the last 20 years, for example, the death rates of children have come down. In 1990, the number was over 2 million children would die before they reach the first year. That number is 50% down today. And that is no mean achievement for a country of our size. Of course, the polio success story, everybody knows. Correct. 2010, not that far, even as 20 years ago, nobody believed that India could get rid of polio. Not only we have gotten polio free, we have remained polio free. Vaccines. India had stalled in the introduction of vaccines for over a decade. In the last 5 years, not only have we introduced a full complement of vaccines, the coverage is going up rapidly, and India now supplies 60% of the global vaccines for around the world. When, you know, for example, meningitis, you know, is not there in Africa today. It is thanks to Indian companies and India.
Yeah.
So there are a number of areas in which you have seen tremendous success happen.
Yeah. Preeta.
So I was actually amazed by those 5 questions, and I hope this conversation will answer some of that as we go along. And so talking about celebration healthcare, we've been in the business of caring for the past 35 years. My dad was, you know, a true American NRI, enjoyed himself, 4 daughters. Why should I come back to India? And he came only because his father said, you know, I'm not celebrating your success. You need to come back and do something for your country. So that happened. It was hard, but, you know, we did what we had to do. We started where we had to do. I think Indian healthcare has come a long way, and there is no going away from it. It is a fundamental right. And like the dancers woke you up a few minutes ago, there are many wake-up calls which need to be done in the area of healthcare. But having said that, I think there's some tremendous strengths which the rest of the world is looking at India already, learning from India, and I'm not even going into the pharma sector because we're really providing drugs to most parts of the world in many ways, including in innovation and filing of, you know, the newest of new molecules. But having said that, we remain the highest level of clinical excellence at the lowest cost anywhere in the world. You know, China challenges the rest of the world on low-cost productions. We can stand up tall and say that we can challenge the rest of the world in the highest levels of clinical care. I agree it happens in pockets. You know, we have challenges of geographical and financial access. We do. We have to look at ways to overcome that. Financial access, there is now universal insurance. There is Ayushman Bharat, which has, you know, at least been launched. Nobody had the courage to do that either. So we have different models of financial access. But in a country so large, you cannot get a prescription overnight. You know, it's a journey. It's, you know, we have a 5-year, 10-year, 25-year milestone. But I think it will happen. It has to happen. There's geographical access. You know, we have centers of excellence in the metros, air-connected, medical tourism. And then you drive 300 miles out, we're still worrying about good, clean drinking water. So how do we really mitigate geographical access? To me, is a bigger problem than financial access. And to do that, different modalities. We've been lucky as a country, we've leapfrogged in technology. Thanks to everyone, you know, we don't have to go through the pain or the path which the developed nations like the US had to do. We have mobile technology, state of the art. 4G going towards 5G will help us with healthcare. So I think the geographical access will use technology to a large extent, but it will happen. You know, your doctor may be sitting somewhere, maybe in one of the IITs, and they will provide through telemedicine some of the best possible clinical interventions. So I think we've got a lot of strengths. We've got the largest English-speaking workforce, but have we skilled them in the healthcare sector? Not yet. But, you know, so this is all work in progress, but there is a huge silver lining at the end of the cloud. In fact, I think the clouds are disappearing. So that's probably what we have to celebrate.
Wonderful. Wonderful. Sasi.
I grew up in a family of health professionals, doctors, and I was the oddball out who came to IIT Madras and had a career outside healthcare. But healthcare has been a part of something that I've seen quite closely over a long period of time. And if I were to call out over the last 20 years something that's really changed, I must talk about a very personal thing with respect to polio. My father was an orthopedic surgeon who went into polio corrective surgery early in his career, or maybe around mid-career point. And I remember in the 80s and 90s, he used to spend a lot of time away from home doing camps in all parts of India because the prevalence of polio was so high. So many people were afflicted by the disease, or in some way their mobility was impaired. And he used to do this, and on retirement, he actually set up a hospital in Vizag, which did corrective surgery and polio. And in the initial years, there used to be tremendous number of people who used to come from all parts of India to get corrective surgery done. Now, nearly 20 years after that hospital had started, there's actually a trickle or less. And this talks to the success of the Indian healthcare system in completely eradicating polio and making it a distant memory in some sense, rather than something that this generation. Very personal example, there are many things that I can talk about. And as an aggregate, I think statistics say our life expectancy has gone up in the last 20 years by 10 years. So from 58 to 67. So in that leap has been possible because of the miracle of Indian healthcare. And I think we should celebrate a lot of successes that have happened along the way.
Thank you. Can we have a huge round of applause for India and healthcare, please? For some of you who came in a little later, in the spirit of kind of starting on a celebratory note and waking people up after lunch, the panelists just spoke about what to celebrate in Indian healthcare. As many of you, none of these panelists need too much of an introduction, but the contribution that they have actually collectively made is phenomenal. And I'm going to take this opportunity to request each of them to talk about what is the issue that they were trying to solve in Indian healthcare, what was the endeavor that they made, and what impact has it had on Indian healthcare. Nachiket, I'm going to request you to, again, get us started on 2 counts. Number 1 is after your, should I say, chapter 1, if you will, in financial services innovation, you actually launched a chapter 2 a little while ago in the healthcare space, and with a very innovative model through IITPH. It'll be fantastic if you can actually tell us what you were trying to address, what did you do, and what is the impact. After that, we'll go to your BMGF story, but it'll be lovely if you could educate us on what you were trying to do there.
Yeah, of course, I was just one amongst a large team of people, and many others were involved. But the core problem we were trying to get to was this issue of primary care. Because people keep saying that doctors will not go to rural India, there is no facilities available, how can services be offered? There are a number of challenges to that. It's not a simple answer. The narrow question we were trying to answer is, what does it mean? Is it even feasible? Or are we talking about, not man on the moon, man on Mars? And it's just, the journey is too long. And that was the effort that we were trying to explore. And one of the questions people asked us is, why Tamil Nadu? Why not start in Bihar? Why not start in... But see, our intent, at least at that point, was not to try and solve the problem. Was to try and understand, is it even feasible? So we wanted to go to a place where everything is not a problem. Because then you don't know. Did you fail? Because there was no power, there was no internet, there is just nobody. Or is it, there is some fundamental barrier that nowhere in India can be solved. And Tamil Nadu clearly looked like a place. So in rural Tanjavur, we got started. We had the good fortune of having a sister institution nearby that had already got power, internet, all that sorted out.
Yes.
So we could simply piggyback on their hard work and try to develop a model in which, rather than use telemedicine or do only basic preventive services, to try and see how far can we offer at first point of contact full curative care. Of course, preventive, promotive, but full curative care. And we went almost up to 60%. Today, I believe with technology, we can go to 98%.
Yeah.
In a tiny place. Cost us less than 2 lakh rupees to set up. Total cost to us, including medicines and diagnostics, 50 rupees per contact.
Yeah.
Almost all the body systems. The good thing about that is, while that effort itself, we took it to a point and then shut it down, because the learning from that was complete. There's still more to learn, but at least what we could do is complete. If you look at the guideline that the government of India brought out in primary care, called Health and Wellness Centers,
sure.
2 models have informed that guideline. If you read the guideline, it references both of them extensively. One is the Sugavalva ICTPH model,
Yeah.
and the other is from JSS in Bilaspur. These are the two models that have informed that thinking. And a lot of the work around the use of Ayurvedic physicians for primary care, many people have been talking about it, but I would say our work also was instrumental in persuading the government to make that national policy.
This is fantastic. Just to provide a bit of context of what Nachiket was rather brief in explaining the tremendous impact that they have had. But just to put this in context, India needs, by WHO standards, something like 1.2 million doctors, correct? We have 600,000. That's really, we have half of what we need. The medical colleges are adding at the rate of 30,000 doctors a year. So by the time this problem gets solved, it will take a long, long time. However, second is that while 70% of the population is in rural, only 30% of the doctors are sitting in rural. The silver lining, though, is that there are about close to 600 to 750,000 doctors who are trained, or I shouldn't say doctors, but those who are trained in alternative fields of medicine. And what really your experiment did was to bring them into the formal system, if you will, through a bridge course and get them to provide these services. Is that right?
I would say bridge course, and in this audience, power of technology, protocols.
Yeah.
Because also what you're starting to discover is that the trained GP, A, hard to find, B, knowledge is changing so fast that actually he may turn out to be your worst enemy. Because he's relying on stuff that he learned 25 years ago.
25 years back,
For example, in breast cancer, right? Clinical breast exams, self-exams, they are no longer the right pattern of treatment. Right? But a lot of the GPs may not know that. Right? There are newer approaches that need to be called in. A less trained so-called doctor, but more horizontally trained.
Right. And
in
what
the
did
use
you do
of technology.
For that,
Sorry?
What did you do for that? How did you get them there?
So what we did is we launched a 6-month program. And then an aggressive apprenticeship effort.
Got it.
Do you know how to, put a tube, needle in the vein? Do you know how to intubate? Do you know how to listen to heart and lung sounds? Do you know how to use systems and search what is going on there? Do you know how to follow protocol? And we took 80 protocols that we trained these people. Now, we didn't have AI, we didn't have all of that. This is a long time ago.
Correct.
Today, all of that is possible.
Right.
So you could go much further out.
That's right.
And make sure that patients are served at first point of contact, 5 minutes from your home.
Absolutely.
15 rupees a consult.
My God.
Right? It's a price point that virtually anybody can afford.
It's completely disruptive change. Sasi, can I ask you to talk about what you and Sonali are doing at Cypher in the space of oncology and cancer, and provide some context of why it's relevant? And
so I think, Prashant, the topic that this panel is kind of debating is how can we be a role model in global healthcare. And I think we started by talking about the success. I think India's success with infectious diseases in some way has created the opportunity for it to leapfrog on another set of diseases. And that's exactly where the focus has been for us. Nowadays, 60% of the mortality in India is because of chronic diseases, no longer infectious diseases or injuries or accidents. And with chronic diseases, it's a condition that you live for a long time.
Correct.
And it's not just one condition. Some people might have multiple conditions that they're managing. The Indian healthcare system has to now rise up to this challenge. And chronic care has to be provided in hospitals, in dispensaries, in health and wellness centers, at home, and different contexts of care have to be taken care of, because it's not one place that this happens. Also because the way Indian healthcare system has developed with the public healthcare system, the private system, it's a rather fragmented model. I've lived for 8 years in the UK, where the NHS as a unitary system takes away confusion when there's an issue that the patient has to resolve. And it also has protocols that Nachiket's been talking about, quite strong protocols about how to treat every case and ensure that an institutional response is provided rather than an individual doctor's response, relying on 25-year-old knowledge that the doctor might have. So in that context, what we're trying to do is, for chronic cases, how do you kind of handhold the patient right from the point there's a diagnosis to the point of logical conclusion of that treatment? And how do you kind of work with and partner health organizations, healthcare professionals in doing that? I think they all have to work together. It's not one competing against the other. As you said, we are only 50% geared in terms of number of doctors that we need for this kind of a population. So we have to use technology, we have to use allied healthcare professionals to really augment the capacity and do the end-to-end care for chronic cases. And we started with oncology because, again, it was a realization close home when 3 cases were detected in quick succession when we came back, and we found a lot of confusion, a lot of anxiety, and a lot of difficulty in accessing the doctor. The doctors oncologists in particular, are kind of fully occupied with the number of cases that they're seeing every day. So it's this lack of access kind of creates a lot of problem for the patient and impacts adversely the outcome the patient has. So we are trying to see how to improve the patient's outcome, how we can ensure that the median detection stage in India for cancer is not stage 3, stage 4, but stage 1, stage 2, where the burden is much lesser, the mortality is much lower. So how can we kind of just move the metrics in chronic care across disease categories is what we're trying to focus on. But by building a very complementary solution for doctors and hospitals to use.
So is it fair to say early detection and integration of the different parts of the health system working together, that's the innovation you've kind of brought in?
That's what we're attempting. I wouldn't say it's success yet. There are lots of people working on this area. I think that's what our objective would be.
Terrific, terrific. I'm now going to request Preeta to share a few thoughts about, we all need, there's little introduction that the Apollo family needs. It's basically synonymous to professionalization of healthcare in India. And it'll be fantastic, Preeta, if you can talk about what has really been the endeavor of Dr. Reddy, all of you in the Apollo family, towards what have you really tried to do in the last 20 years to Indian healthcare?
So there's the newest theme at Apollo is Apollo never sleeps. You know, every time we think something has been done, then the challenge just seems so much bigger and so much larger. My dad came back because, you know, he felt a good doctor had to come back to India. That was all. Then the hospital started because, you know, his patients could not afford or go abroad for heart surgery. So we did the first hospital. Banks were not even funding hospitals at that time. So it almost, you know, you had to talk to people in power and change legislation for banks to even come forth and fund hospitals. So that happened. But now, when you look, you see an ecosystem of high-quality healthcare, and I think that has probably been game-changing for the country. And one of the biggest innovations, which I think we should all take credit for as a country, is one is we've brought fantastic standards of intervention and care. But the second is this financial access. We started it in my dad's village in Aragunda. We said we'll take about 50,000 lives, insure them for 1 rupee a day. That was the first insurance which happened in the country. And for 1 rupee a day, they could actually access the highest level of healthcare because, then it was co-insured and then somebody underwrote the risk but the states took it up, and in Bangalore, the Yashaswini scheme happened. So in pockets, many of these schemes have happened. It might have been a political agenda, but it was a great agenda for public. So, literally at 1 rupee a day, or the chief minister's schemes, or Yashaswini, there are many pockets where we're providing financial access. So to me, that was, I think, a large innovation which has happened in our country. And for example, recently, Thailand is looking at India for models for, universal access, which is a great thing. Thailand, was the place where people spoke about for medical tourism, and now they're looking at a country like ours and saying, how do we provide universal health care? So I think the world is becoming a smaller space. It's changing. And so we do have some kind of financial access. But the disease burden is huge, and, we have to be completely aware of it. We are home to 17% of the global population. 21% of the world disease is in India. 60% of global cardiac cases come from India. And with the third largest pharma market globally. So there's a bit of a dichotomy there. We're actually providing drugs to the whole world. And are we getting enough solutions to heal our own country is probably, the next biggest challenge. And we have to figure that out. And also, can we really catch disease early? There are ways, there are means, there's technology, there's artificial intelligence, the clinical protocols to teach people to, help with early detection, because the disease burden is huge. The NCDs, diabetes, cancer, and heart can literally, it's the biggest tsunami coming ever. People talk about terrorism. They even talk about bioterrorism. They don't talk about the terrorism which NCDs are creating in large countries and large economies. So as we say, we've innovated, we've done, you look at the road ahead and it's a bit daunting because there just seems to be so much more to be done.
Fantastic. We are now going to move into some of the big moves that we're going to make, that India needs to make to become the role model for global healthcare. But a round of applause to these people who have actually shaped Indian healthcare in a very, very meaningful way. Let's pick up play on the chronic disease part of the whole story. Let me ask the audience another question, if you will. What proportion of the world's population suffers from obesity today? 40%. 40%. Any other number? 25%. Okay, fair enough. The average, 60. Did somebody say 60? 70%, mamma mia. No. The world's not gone that bad. It's about 30%, so average of 25 and 40. But the prognosis is that could become close to 30%, 40% by 2030 if it goes unabated and if we don't make an intervention. And a lot of what Apollo has brought is a tremendous thrust towards high quality healthcare, what you're doing in Aragonda in the village, and another thing the chairman is very proud about, which is health checks and detecting early. Nachiket spoke about primary care, Sasi spoke about detecting cancer early and chronic diseases early. If we can just go 20 years forward and ask ourselves, what aspiration should India set for itself? And what are the one or two big moves that we will need to make as a country? How should India think about it? Nachiket, go for it.
See, we have to, in some ways, think what the achievable ambition is and what is outside of our aspiration. If I look at, are we spending enough money on healthcare as a country? The answer is yes. We are spending somewhere near 4.5–5%, and the estimate is more than enough money. But yet, as Madam said and you said, the statistics on a number of diseases, of course NCDs is a big problem. Unfortunately, TB continues to be an enormous problem. We lost 3 million people last year on TB. Child health continues to be a problem. While I'm very proud that 2 million came to 1 million, 1960s technology, if properly implemented in India, will reduce the current million deaths to 100,000. Right? So we are in some ways 70 years behind where we could be. Right? So there's many continuing tragedies despite this enormous expenditure. The question is, how do we square the circle? We are spending enough money. We have enormous challenges to make things happen. Now, there are no silver bullets, unfortunately, to say this, that, and the other. But we know a few things. If I study, there are 80 countries around the world that are ahead of us. Yeah. Many more, but certainly 80. And on a path that is a very positive path in terms of getting there. Some things we know they have done, which we will need to do. One, people spending money when they go to a hospital from their pocket. India is almost the only country where you see this happening.
2/3.
Right, that people show up at a hospital, 50,000 rupees, they have to put cash or credit card or something to make it happen. Otherwise, they will not be even allowed to go inside. Right? We have to fix this. Right? It's not that people don't have enough, they're spending enough money. Spending it when you need the care is a bad design. Right? One very, very important aspect.
This out-of-pocket, oops, as it's called.
Oops, at point of service.
Yeah.
Tax is also out of pocket.
Yeah.
It's at point of service is the problem.
Got it.
Right? The second, kind of enormous issue for India, and, states like Kerala are experiencing this in some ways much more. No high-quality health system allows markets to determine prices and protocols. This logic of demand and supply, telling you what should you price for a C-section, what should you charge for a this, that, and the other, not even the US. It's the closest to the free market system that we have. Prices are controlled. Hospital licensing is controlled. It's very much the pre-91 Indian era.
Yeah.
That prevails in every single high-quality health system. It's not that most have it and some don't. We are going to have to battle this because, this is an important issue that if we don't do something about, will, I think, continue to... In fact, the fact that the government delivers healthcare is the exception.
Yes.
That is not the rule.
Yeah.
Government delivery of healthcare. People think UK is government delivery. Actually, GPs are all private.
Private, yeah.
There are private individuals.
Sure.
In fact, almost the only country that has a pure government-run system is Cuba. Tiny island nation, a very different political structure. It's almost the only country that you see it. You see various proportions of it, in different parts of the world. 100%, that's the only place you see. Clearly, it's not possible for us to replicate that idea, even if we had enough money.
Yeah.
Now, there are many more challenges, but are these one or two things doable? My belief is they are.
Yeah.
There are no absolute gaps. I argued to you earlier, I do not believe we are suffering from a shortage of doctors or nurses. Thailand, madam mentioned. They didn't even have nurses. They started with village girls and over a 20-year period built family nurse practitioners that could do oncology nursing.
Yeah.
Right? India has no shortage of people who are looking for jobs. Right? And ultimately, it's a matter of training and skilling. Much of healthcare is working with your hands to do some hard work. So there's no fundamental barrier to us achieving a really high-quality health system outcome. The only sour note I will strike in all this hopeful story is that if we don't take those actions, we as a health system will regress. Because markets are taking over, they're becoming more and more dominant. We don't have the money the US has. We look down on the US health system, rightly so for many reasons, but they're 95% insured.
Yes.
We are 95% uninsured.
Uninsured, yeah.
But yet, we have all of the ills of that system with no money. Right? So, there's an urgency to these actions that every day you delay, it becomes harder. Yeah. And there are states in India, this one, Kerala, where you can see the beginnings of the free market.
Yes.
And where do you see, why is it that these states, despite enough expenditure on healthcare, at the family level, hypertension is so high? Because nobody is seeking primary care. Cervical cancer mortality, one of the easiest detectable, early preventable cancers. You can't detect it by creating better hospitals. That is 28% survival rate. At the age of 18, at the age of 20, you have to get a series of steps. Not hard.
So there is a major move according to you, in one, making sure that people are covered, they're not doing out of pocket at the point of care, and number two, around there is a move that you believe is required in the space of primary care?
Control. Primary care will come as a derivative.
Yeah.
The minute you figure out how to decide your health system. Currently, we are taking a passive view.
Yeah.
Let it evolve as it evolves from demand and supply.
Right.
That's a great strategy for toothpaste markets.
Yeah.
Great strategy for automobile markets. Terrible strategy for healthcare.
For health. Preeta, what do you think? What would you like India to aspire for, and what are the one or two big moves that you think India should make?
See, I think, I don't know how much the lack of, money is there in the system, because just a simple math, if you say that half our population can actually pay 1 rupee a day for 365 days, there's a lot of money available in the system for health infrastructure. How do we deploy it to raise the bar and, how for early detection or the best possible intervention, I think are the models which have to evolve in the future. Right now, unfortunately, the government works completely, almost in an animostic way with the private sector. And I don't think that's the right way forward, because if you look at the US market, for example, they aren't really government hospitals. The government pays for Medicare. And the private sector, whether it's for-profit or not-for-profit, have a very regulated system on pricing. People understand, people know what the pricing methodology has to be, because, otherwise you don't get Medicare. So I think some of those learnings have to be adopted into our country. The prices have to be fair. You have to pay for what you get. But having said that, if you're not covered by insurance, if you're not covered by Medicare, and somebody from, let's say, somewhere in the world goes to Houston or to Cleveland Clinic, then what they pay for healthcare, that cash down is humongous. But why not insure ourselves? Why not be an educated public and find a way so that we don't really pay when we have to, when there's a disaster? So I think this kind of communication is very important for people. I would not agree with the fact that, if we say that there is no money in the system, because anyone can afford 1 rupee a day. Look at the cell phone penetration, and it's not coming for free. Our mobile phone penetration is 800 million. Why can't health insurance penetration be half of that? Let it not be 800. You mean to say they can't pay 1 rupee a day? 400 million people in the country cannot pay 1 rupee a day to see that they are covered during disaster. So I think it's more about educating people. It's more about communication. And I know health systems throughout the country are really trying. If the government would actually, look at private sector as a partner and not like a contender for politics, because there is no time really to get into politics. You just have to deliver care. And then can they really focus on the primary? Can the government really focus on early detection, early intervention, and communication to people to stay well and healthy would probably be a better model for the future. And then find a good ethical way to pay for, the higher levels of intervention. I think these are the models which need to evolve for a country like ours. Will it evolve? I'm sure it will, because I think our people have become more discerning. Data is available. You can get information wherever required. So I think it will evolve. It's not there today, but I don't see it not happening.
I'm soon going to open up to the audience, but I do want to raise one topic that has actually come up in the Indian health system quite visibly in the last couple of months, which is this whole Ayushman Bharat scheme. One of the learnings for us seeing other health systems has been that it's very important to address access before we address quality. And I guess this scheme or this move is an attempt to do that. It's supposed to cover 10 crore families, supposed to cover 500 million people, insured to an extent of 5 lakhs a year and so forth, supposed to result in an outlay anywhere between 2,000 to 12,000 crores that's claimed. how do you all see the impact and relevance of this scheme? Sasi, do you have a view?
So I live in a state which had the forerunner for Ayushman Bharat, Arogyasri, and it was I think it actually in many ways inspired Ayushman Bharat to a large extent, and it did its job. It did expand access in a fantastic way. I think there's been a lot of research on how the people were able to access even private care, which they were earlier finding hard to access, and how the monies that were dispersed through the Arogyasri Trust have been allocated to different parts of the health system. So I think it is a great step forward to solve the problem of access. And as you said, maybe that is indeed the first step we have to go on before we kind of get to quality. I think the one thing I would say is that the whole push around preventive has to come through much more clearly. It may be in the health and wellness center design and other things embedded in there, but it isn't kind of come through yet in a strong manner. As a country, we've done pulse polio, we've done Puliraja for AIDS control and all of those very successful campaigns. We could easily replicate those on the NCC side, which has been referred to as a new wave of terrorism that we are kind of looking into. So I think we should focus on preventive in Ayushman Bharat context as well. So that missing link has to be closed. And I think the other part is access has been created, but India will require Indian solutions, and there's a lot of innovation. We had a panel on digital and the startup ecosystem early in the morning. There are lots of experiments going on there. We have to find a way to harness that ecosystem for healthcare access improvement as well as quality improvement if we want to leapfrog over the next 20 years.
Understand. Just to play the devil's advocate, and Nachiket, it'll be lovely to get your view. You know, we talk about 1.2% of GDP is the public health spend. It's abysmally low. Any well-functioning system actually spends significantly more. I'm not talking about the total 5%. I'm talking about the proportion of public expenditure on healthcare. Now, 2,000 to 12,000 crores is, frankly, you know, it's not a big swing from given India's GDP. It's anywhere between 0.02 to 0.15%, whatever that number is. Is this material enough a move for us to be 1,200 rupees a family? Is this material enough a move for us to get to the coverage point and address the first thing you spoke about, which is out-of-pocket expense at the point of care?
My sense is that the journey towards health systems design is a multi-part, multiple pieces are needed. And you know, Ayushman Bharat has attracted a lot of attention lately. Everybody has their favorite parts of it. Everybody has parts that they don't like. If you ask me what do I like about it, creation of the National Health Authority. It may do what Madam just said, that it may finally take a view of the entire health system. Private, public, everybody. There is envisaged a unified IT architecture in the entire system. Right? It is possible, if you go to hospitals today, what they really have right now are billing systems. They don't really know anything about your even BP. Right? They know you as a patient. If you go and give your patient number, the only information they have about you is when you came last, how much you paid. That's all. Nothing else they have. Right? As you build out this IT system, it's possible hospitals start to build this issue of pricing and protocols. Now, I know there has been a lot of debate, is this pricing too much, is this pricing too little? But I would say from a repeated game sense, I would much rather start with too low and revise upwards than start from too high, because then revising downwards is impossible. Right? So one could argue these are all terrific moves. Right? And now, will this be enough? Will this usher in the age of universal health care? For a number of reasons, I would say this is just one of the steps that is needed. You know, I really like some of the comments earlier. Why can't, for example, 400 million people buy some form of insurance? Now, one beauty of Ayushman Bharat is that it offers finally what we call the public option using Obamacare language.
Yeah.
If they opened it up and they told people 1200 rupees premium, not quite the 1 rupee a day, right, per family, but not that far away, 5 rupees, 6 rupees a day.
Sure.
Right? Anybody can buy. Right? Now that could change, right? Suddenly a bunch of people, today if you were to ask people in this room that do they have it, does their driver have it, does the taxi that they took, does he have it? He can afford 6 rupees a day, but there's no product in the market.
Yes.
Or even if there is, he doesn't know, is it good, will it work? In Ayushman Bharat can give you confidence to say, I have 12,000 hospitals nationwide, you migrate from Nagaland to Odisha to Kerala, you can access it. So it's building pieces of architecture that I think are essential if you're going to, build the health system of the future.
Interesting. Preeta, how does the
Just one
provider
point.
world?
Sorry.
How does the provider world look at the Ayushman Bharat scheme? It's 80 to 85% of CGHS rates. It's a different debate. And how does your world look at
So
it?
there are 2-3 aspects. One is, of course, on the health data systems. I think it has evolved. There's a lot of movement, not only in our own system, but with the government, good private healthcare providers, to really take it beyond the point of the billing system. Simply because when somebody comes in, you can cut the cost of care. You don't have to run somebody through a whole bunch of tests because the system has already showed that someone has done the required tests. So we're actually cutting costs by having a good, robust data system. And I think a lot of healthcare providers are really, approaching that kind of methodology. I'm not going to say Apollo, but look at TCS, for example. They're in the area of cancer care. But their digitization, the way they're providing it for others, is fantastic, and so much of information available. So I think that is happening. How do the private sector look at Ayushman Bharat? I think it's a great move. There's no going away from it. Some of it is political because of the way the costs are structured. So be it. I know it will evolve. But it's a little hard to say that, they will pay a private sector provider 9,000 rupees for a cesarean. When we're not really prepared. We may be prepared in the future. You might have consumables, you might have done your beds right, you might have trained the right doctors to, which means it boils, if you say 20% goes to the clinician who does it, it's a couple of thousand rupees. So I don't know if that is possible. You could do it in a government hospital because you don't think a specialist is coming and doing the delivery. But if you come to a private sector, it's a conscious, trust factor between the, the patient and us. And you can't tell the doctor, hey, listen, this is all you're going to get.
Yeah.
So I think there's some of those paradoxes, dichotomies, anomalies which exist right now. But I think it's just the first step. We've just started. There hasn't been enough of active dialogue between the private and the public sector. So I think there will be a methodology where both will coexist. I think overpricing in healthcare is not required. But all this happened because private equity was asked, allowed, access into investing into private sector hospitals. How did it scale up and mushroom? They want a double-digit return on investment. So if there's a better way to finance healthcare, you won't be getting into this trap. So I think we must educated people must keep that at the back of their mind. And I'm sure there are answers.
Yes.
Answers are out there. It has to evolve. We've come this far. And I think the future we will leapfrog because, now people are a very conscious audience. So it will happen.
Thank you. Thank you. Any questions from the audience? I can see that we are kind of running out of time, but are there any questions? We can take 3-4 questions. Yes, please. 1 or 2, I'm told.
Yeah. Okay. I have just 2 questions. Though they are not directly related to the healthcare model that we are talking about, I think both the questions are based on ground reality. The first one is, right, we were talking about the general practitioners and reskilling them. Now, maybe I'm wrong. I would be happy if I'm wrong. we are able to see a kind of pattern wherein most of the doctors are not relying on their own diagnosis and are always going for diagnostic tests, even for some simple ailments. Is this because they want to go with a resource utilization mode, wherein they want to utilize all the equipments that they have bought out, spending heavy investments, due to which they are bringing in or they are increasing the cost for the patient? One. Second,
Can we keep one question? Let's get that out of the way, and we'll go to one other last question. Yeah, please.
Okay, I'm going to take that because, I do represent private sector here. Unwarranted tests are completely unethical. You have to be high touch first and then high tech. And if the clinician does not use, 5 years of learning for undergrad, 2.5 years for a specialist, and just runs a whole bunch of tests through somebody, I think it's completely unacceptable. In the US, the insurance is actually paying the doctors not to prescribe tests. In the UK, they're paying doctors not to prescribe. They're incentivized not to provide. So this asset utilization, pushing people through diagnostics and all that, has been an ill which has come into the industry, but it's not the right thing at all, because a lot of the tests are unrequired, or somebody would have done the test and no one's bothered to check it out again. So I think to answer your question, it has to be more regularized, and it has to be ethically done, and institutions have to go through a peer review to see that an ex-doctor is not doing it for whatever reason.
Thank you, Preeta. One other question from somebody here.
Drone policy. In India, we are going to, in coming days, we are getting a drone policy into India in December. So, what are the possible ways it will increase the connectivity of healthcare in India?
Could you please?
What are the possible ways it will increase the connectivity to people in India?
What policy did you talk
Drone policy. Drone policy.
Drone policy.
Yes.
Drone policy connectivity. Does any of you have a view on this?
I think I'll just provide a perspective. I don't see how exactly drones will fit into this equation. But I think given the situation we have, where we have only half the capacity we need of clinicians, we have most of them concentrated in urban areas and the bulk of the population in rural areas, technology will play a role in bridging the gap, both the capacity gap and the geographic gap. And I'm sure as bandwidth improves, as other things improve, some of this will become much better, and hopefully care will become more democratized.
Just a quick response. Drones are currently being used in Africa for remote delivery of medicines extremely fast, right? Because there are many parts of the country you cannot reach quickly, and roads is a difficult challenge. And smaller dosages. One individual needs a TB dose. Somebody needs something else to get it there. The second big area is what they call landscape epidemiology, to try and understand how disease burdens are spreading. For example, we know that if you take rice field patterns, if you have a checkerboard pattern versus a solid pattern produces a lot more malaria than a checkerboard pattern. Right? Now this either you can see from satellite, or if you don't have enough data, you can see from drones. So clearly another possibility. My own belief is it will have a much bigger impact on agriculture, but on healthcare also it could have a positive impact.
Very interesting.
So we were the first ones who tested the drones out, by the way. It is delivering drugs from point A to point B. But there's this very altruistic view of can we transport organs in the event of a transplant? I think we have a long way to go, so we shouldn't get carried away. While it sounds fantastic, one little bit goes wrong somewhere, you've lost a precious organ. So I think we have to be very clear about what it can do, what it cannot do, what we should do, and what we should not do. While it sounds fantastic, I think we need to fix our first our access, primary health systems, all that, before we just get into this whole exciting area of drones.
Wonderful. I'm afraid this is a topic I'm sure that can go on for a long time. We are woefully behind time and we need to move on to the next panel. So I'm tempted to actually, if you don't mind, draw this panel to a close. You seem to have a very pressing question that you can't get your heart out of. Okay, that's really the last question, please.
Thank you very much, sir. Ma'am, the question is to you. India accounts for the highest number of road accidents in the world. How can you contribute in providing the immediate trauma care so that those fatalities can be, we can work on them. We can save the lives of the people by providing the emergency health care.
Yeah.
So this is what has happened. If you really look at what's happened in India, the ambulance service has gone up tremendously. 108, whatever it is providing care in a lot of locations, not everywhere. But if you look at some of the developed countries, then they have helicopters going in to really extricate people. Do we have enough trained paramedics now to do it? Again, we are training some 20,000 paramedics every year, but that's not enough. It's a large country. So if your question is, do we have it? I don't think so. Are we thinking about it? Yes, we are. And to me, it's work in progress. But by the way, our roads are much better than what they used to be. People's awareness on road traffic accidents is so much better. So while the numbers are going up because, people have access to vehicles, the actual numbers are not that high anymore. So, there has been some amount of control on RTAs, and that's what we're seeing with data.
Terrific. We are going to really have to close just now. So very quick summary, India has made tremendous strides in the last several 20 to 50 years in terms of healthcare. Many pressing problems remain that need to get addressed, and at an urgency like Nachiket spoke about, that's going to be very, very important. We have made several innovations and are taking the right steps, but many more steps yet to get done. And hopefully in the next 20 years, we will be a model for 20 to, let's say, 40 years. We will be a role model for healthcare worldwide. So wish you all very well, and thank you, panel, for taking the time. I'm going to say it will require many hearts and IIT brains to get there, though.
I request Ms. Jaipriya to please honor our moderator, Mr. Prashant.